sizing and alliteration, but probably the simplest one, does it need to be a discussion all the time? I believe that we need to discuss it. And so we start with the question, and you can vote right now. So the voting runs, almost 100. I think that's enough. Oh, more than 100. Okay, we can go back to the slides because all think that sizing is still an issue. Please go back to the slides. This is a very nice publication by Wunderlich and co-workers who showed the diversity of the left atrial appendage and its complexity, so sizing is really an issue. And it would be a dream to have one size fits all or make LAA occlusion devices great again so they fit in everything. But currently we have the problem, we have different devices. So is sizing actually a clinical problem? Does it occur during the procedures? And now we have the data from Apostolus group, and you know that quite well. We have only a small exchange rise for devices, but still, it's 6%, 7% of devices who need to be exchanged because they are missized. So the key question is really, can we look only on our anatomy data, or do we have to take any more information into account? And in this respect, it's quite nice to go back to animal studies and look what people did in dog models and looked at loading conditions and the size of the left atrial appendage. And this paper is quite interesting, as they showed, with increase in loading conditions, increase in the left atrial pressure, at least in a dog model, you can see that the left atrial dimensions increase. So we have a complex structure which actually is dependent on volume and loading conditions. And as you can see from this very nicely done study by Spencer et al., which was published in the JACC Cardiovascular Intervention Journal, that volume loading during percutaneous left atrial appendage closure was investigated, and those authors investigated typical population of patients, and in this group you can see that the final left atrial appendage pressure was much higher than in the dog model, and they gave around 1000 cc of saline, 855 exactly, in the patients, and they could demonstrate at least with 2D measurements, that they increase during loading and increase in left atrial pressures. So, if you can select one modality of sizing, which would it be? You can vote now. So we go back from fusion to separation. I think we have 102 votes. Okay, most of you would actually go for TEE. And you can show the slides now again. So that's what I anticipated. And this is a quite nice study who investigated, actually compared two-dimensional and three-dimensional TE to CT measurements. And what you see is those Blend-Altman analyses. And you can see the difference between CT and 3D TE and 2D. You have a larger variety of measurements, and the differences are larger with 2D. So it's highly recommended to look at 3D data if you use the TEE. We compared two-dimensional and real-time 3D TEE and angiography for assessing left atrial appendage anatomy for sizing left atrial appendage occlusion systems, and assessed the impact of volume loading, and published this more recently. This is ahead of print. And we had a number of aims with our study. First of all, we wanted to compare different methods for the assessment of LAA and determine the accuracy. Second, to determine the influence of volume loading on LAA dimension, including three-dimension measurements. And we wanted to develop a method for optimal sizing the left atrial appendage occlusion device with the Amplaza devices. And furthermore, we looked on follow-up to find the optimal compression of the device to avoid device leakage. So this is our patient group. We had a total of 46 patients with typical patient population, 75 years old. And you can see these are the measurements at baseline, the previous day TE, then procedure baseline, and after volume loading, there is a significant increase. However, not as much as in the doc model, because we already had elevated left atrial pressures in most of the cases. And you can see that this holds true for the three-dimensional TE dimensions as well. You can see that the perimeter increases considerably when you measure after volume loading. So there is a significance of volume loading, so please try to maintain LA pressure higher than 12 mercury. And on average, a volume loading of 1000 cc is recommended. In our study, we gave our patients 10 to 15 per milliliter per kilogram body weight. And then you should measure the LAA dimensions after volume loading. So there's another question. Traditional device sizing has been based on the maximum internal dimension of the LAA. First, you can vote no. That is still a good way. Second, the internal parameter would be a better reference for device sizing. And third, very difficult topic, I have no idea. Okay, maybe we can see the results. Okay. Lots of people have more than no idea, so that's quite nice. And there is some discrepancy between 1 and 2, still a good way, maximal diameter or the internal parameter. We can go back to the original slides. And there's an interesting new manuscript on CT sizing for left atrial appendage closure. And they looked even on the outcomes, but they looked on the perimeter as well. And this is printed ahead in the European Heart Journal of Cardiovascular Imaging, so you can read it in the next few weeks. And what you can see is a scatter plot, again, a Blend-Altman plot for the difference in maximal diameters on CT and on 2D TEE. And you can see there's a large variety. So it's very difficult to take the maximum diameter quite easily. Furthermore, they looked into the prediction whether device size can be predicted by different parameters. And you can see device sizes predicted by mean orifice diameter on CT was most likely to match the actual device size implanted, at least in 74% of cases. And when you look at the maximum diameter on TUU, was only in 42% of cases. Going back to our work, we did 3D transesophageal echocardiographic measurements and reconstructed in a multi-slice way the orifice and the neck of the left atrial appendage and measured the landing zone. We took the perimeter and the area, and then we correlated those parameters and compared them to the actual device size which was implanted. And as you can see, the highest correlation coefficient was found for the perimeter, and then for the area, and contrast angio was not did not have a high correlation to the actual device size. This is a quite busy bar graph, but it shows you the agreement of implanted device sizes and various measurement modalities. I will show you that the grayish bar part is device undersized, red is oversized, and green is okay, basically. And you can see that volume loading always improves the situation and is very important, so you shouldn't forget about it. And if you look at the angio data and compare the angio data to the TEE, there's not a big difference between it. However, once you add three-dimensional information, the mean diameter by perimeter or of the area, you get much more agreement and less undersizing of the device. Is that clinical relevant? And there's another busy figure which I want to run over with you for a minute. It is clinical relevant because this slide shows you peri-device leaks and compression of the device. We actually tried to measure the compression of the device, and you can see the black bars are no compression, 0 compression, 10% compression, and then you have 15% of compression with the blue bars and 20% compression with the gray bars. And the blue dots are devices without leaks, and the red dots are devices with leaks. And what you can easily see is, on follow-up in TEE, that patients with compression less than 10% had more frequently residual leaks, and this translates also into numbers. You can see that patients with no leaks had an average compression of the device of 14 plus minus 3%, whereas those patients with leaks had less compression than 10%. So in our study, we recommend to have around 15% compression of the device. Can you move on with the slides, please? Okay. One slide back. Please, one slide back. Yeah. Does that translate into clinical practice? I believe yes. We actually investigated and compared our ACP patients to the latest AMOLED patients, and you can see that we have a much lower exchange rate now with this new technique which we use in all of our patients. So I'd like to summarize. Next slide, please. Sizing of LAA devices is still an issue. Volume loading is very important. Try to keep the LAA pressure higher than 12 millimeter mercury. Perimeter of the LAA landing zone is most reliable for sizing LAA devices. A compression of 10 to 15% avoids peri-device leakage. And 3D, TE, and CT-derived perimeter of the landing zone are reliable methods for device sizing, whereas CT exposes patients to additional radiation and contrast agent. Thank you for your attention.